we are going to transition into what we promised we would be doing this evening and what Kelly has set the stage for and Elizabeth has set the stage for. And that is to listen. Listening session is about listening, right? And then we're going to transition to some remarks and a video from Senator King. And it's going to be sort of narrated, and other comments by Edie Smith, who is right here, and who will be the senator's, who is the senator's left hand, right hand, both hands, and everything else. And then we will have a panel of folks who will sit up here, people who have been in the field for a long time, some who are emerging leaders for the palliative care field. And after listening to what all of you have to say, they will be responding to any questions or comments that you might have. So that's how the evening is going to go. And Dr. Mikolakis will be joining me. I'll transition to Dr. Mikolakis, and she will be helping facilitate the listening session. But you will have microphones on both ends of the room. Is that correct, Jason? Yeah. And do you folks know where the microphones are? We will have roving microphone reporters, sort of like the paparazzi, only they're not taking pictures of you, they're just handing you a microphone. So let me introduce my dear friend and colleague, Dr. Lauren Mikolakis, if she's through eating. And she will be saying a few words. You know, one of the things that I've always enjoyed about Lauren is that she always had the courage to stand for what she believed in. You know, all of us in this room have a moral compass, and it takes us where we need to go when we need to go there. And sometimes we do it with a lot of pushback, but we keep doing it. We have the courage to do it and to stand our ground because we know it's right for our patients and families. And I always admire, and that's what I always admire people like Dr. Mikolakis for doing that, who have the courage of their convictions, sometimes in spite of all odds, who stand their ground and fiercely defend what is ethically and morally the right thing to do for patients and families. Sometimes our healthcare system doesn't always appreciate that, but we do it anyway, and we all do it differently, but we need to do it. And so with that, I would like to introduce Dr. Lauren Mikolakis, who works now. She went back to school to get her master's in public health along with her medical degree, and then she went to work for the Office of Aging and Disability. So she's her own interdisciplinary team, right there. So Lauren, step right up here.
I think she just called me the B word, you know? That fierce thing, that fighting, whatever.
Bless your heart.
Candace, how would you like our panelists to come up now? Is that what you're thinking?
Yes,
I think that come on, girls, come on. Let's go. And we've got, what, Dad? Yep. Yep. And I think it's Jackie, too. Yep. Yep. She's right here. I think these, does this work? Does this microphone work?
Work?
Yeah.
There you go. No, I think you just need to keep it in front of you.
You know, thank you, Candace, for introducing me and inviting me here to speak right now. I wasn't really thinking that's what I was going to do, but thank you for your kind introduction. And you know, I look at these three fierce women who I've known for a long time. Just so proud to be standing here with you, sitting here. So thank you, thank you, thank you. I'm going to maybe just ask you to introduce yourself. Jackie, you want to start?
Sure. Hi, I'm Jackie Fournier. I'm a nurse practitioner. I work for Androscoggin Palliative Care. So that's in Lewiston, but of course it branches out to quite a big region. I started with palliative care at Androscoggin 6 years ago. Prior to that, I decided to start a new inpatient palliative care consult service at CMMC. And prior to that, I was a clinical nurse specialist, and at that time, we called palliative care bridging.
Yeah.
And so now we actually have a word instead of bridging or transition.
Yep.
Hi, everybody. I'm Vanessa Little. I'm a palliative care physician. I'm the medical director of the palliative care service line at Northern Light Health, and I work with the community-based palliative care team, which is well represented at this table over here, calling them out. I've worked with that group, and I'm meeting many of them for the first time in 3D tonight. And I'm also a member of the Quality of Life and Palliative Care Advisory Council.
Hey guys, I'm Becca Hutchinson. I'm a palliative care doctor at Maine Medical Center and the medical director for palliative care for Maine Health. And what else were we saying? I think that's probably good enough. Yeah.
Okay. All right. Well, they're all very humble. They're all very, very humble and reserved in their descriptions of themselves and their experiences and their wisdom. So I guess, I mean, the idea here is to invite questions from this audience for sure. But maybe I'll just toss the first one out there. And why palliative care?
Because it's so easy.
Totally.
Yeah. Jackie, you want to take a shot at that? Why palliative care? You mentioned that it was a transition for you. Yep.
So it was very interesting, that sort of journey, because with the bridging, that transition, I was doing home care at the time, hospice, and where I was working, we were the first ones to do the hospice program in the state of Maine. So we knew nothing. We knew nothing about IDTs. Are you kidding me? We're going to talk to physicians at the same table, and social workers are going to do my work. It was a really amazing and trying time. I know, sorry about that, Robin. And it was a really trying time, but you know what? The one thing that was important in that transition was the recognition that as a team, we were able to do that great work for that patient and families, because one person can't do it all. It's the village. It's the team that did it. So for me, palliative care meant that there was somebody who was going to advocate for those who were vulnerable, and I was going to hopefully see people through serious chronic illness, talking about what they wanted, helping to make sure that they had symptom management so that they actually had a quality to the day till the time that we might be actually having the conversations about hospice. And for me, that meant that was a real intimacy that was really important with palliative care.
So I went to medical school at UNE, so it was a School of Osteopathic Medicine, in search of medicine for mind, body, and spirit. And then I did family medicine, and I did a great residency program, and I loved it, but I felt like it didn't fit to find that treatment of mind, body, and spirit in the medical model I was learning. And I remember saying to one of my teachers, I don't want to learn to do this faster. I don't want to tell patients that they can only take one problem per visit. I thought that wasn't the whole idea of family medicine. And she was like, oh, you'll get there. Don't worry, you'll get there. And I was like, okay. So I didn't want to be changed. And at the same time, palliative medicine became a board-certified subspecialty. So I happened to stumble upon a fellowship and felt like that was just the right place for me.
Yeah, I guess some similarities with both of you. I was an internal medicine doc and was working as a hospitalist. And for a variety of reasons, my husband and I needed a change. And that's the time that I met Lauren, actually. And I was applying for the palliative medicine fellowship up here when Lauren was the program director. And I honestly do not think I knew what palliative medicine is. And I see this in the people that are applying for fellowship now, that it's one of those fields that you kind of have an idea of what's happening when you're not in it, but not really. And so I thought that I was going to do the fellowship, learn some things, and probably go back to being a hospitalist. However, when I started my fellowship, I immediately realized, wow, these are all the reasons that I wanted to be a doctor in the first place. I get to spend time with patients and families. I get to know them as humans, separate from their medical problems, and I get to really sort of help to make sure that they're getting the care that they want. And it was really, I don't know, within a month or 6 weeks of being a palliative care fellow that I was like, I don't want to do anything else ever for the rest of my life. So my home.
Yeah. You know, I think it's just so interesting because palliative care is still a relatively new field. So the path that many of us have taken has not always been direct, right? You kind of bump into things and you figure it out. And so I think if you went around the room here, you'd have probably about 100 different stories of how you ended up in this room here tonight. So how many are actively working in programs today? A lot of you, most of you. Okay. Are you doing well? Do you have challenging days? No, people are just laughing. I mean, does someone want to talk about that? What are your challenges day to day when you're doing your work?
I don't want to talk about it, but I want to ask the panel. I've been doing this for a while, and I'm getting ready to make plans on kind of wrapping up my career, or at least toning it down. And one of the things that I've seen that is frustrating as a program director is that it's painfully difficult to find people to come and work in a lot of places. And I think there are a lot of reasons, but I know some superb hospitalists who aren't willing to take the pay cut. And I wonder, are there any other subspecialties in medicine where we actually make less than the generalists? I think that what we do is so important, and yet it seems to be so devalued. It's devalued by the reimbursement system. It's devalued in compensation. And it seems to me that the harder we work, the harder we are asked to work. And I want to know, how do we deal with this? Because I have done a miserable job in setting limits on how to deal with it. And I think that the people in this work, whether they're providers or nurses or social workers, they have huge hearts. And when there's that next person that needs help, you don't say sorry, maybe tomorrow. So how do we deal with the problem of not being recognized, appreciated, whatever, by the system, by our administrations? And how do we make sure that people keep coming into this field and that people stay in this field without being destroyed? Big question. And I really want some answers.
Do you want to go? Go ahead. You look like you're. I thought maybe you were writing down the answer for all of that.
I'm just respecting you.
Jim, let me ask you a question. Do you think that part of it is because there's not a real deep understanding about what palliative care is at the leadership level?
Yes.
Yeah. Do you feel that way?
I also think that we did it to ourselves because so many of us chose to do this because we are called to do it and we have a passion for it. And we were willing to say, I'll take the pay cut because this is really what I want to do. And we heard you all say that. This is what you want to do.
Well, I think part of the stuff we explored at the level of the advisory council, just also throw this out here, is that there's the way palliative care is reimbursed is not the way it's supposed to be delivered. So physicians are lucky to get anything, right? What does a social worker get for their work in palliative care? What does the nurse get for their work in palliative care, right? The system does not compensate them directly for their work. So I think part of it, Jim, is we're just messed up with regard to how we pay for these services.
Yeah,
Any thoughts about that? Yep.
I was just going to say, I really agree. And as much as sometimes I struggle in, working for fair compensation for the physicians in palliative care, while I'm doing that at the same time, I'm really struggling with, well, wait a second, we're not paying our social workers well enough or our nurses well enough or anyone in palliative care their worth. So it's, it's just going to echo kind of what you were saying, that it's really a struggle.
Yeah.
Can you explain what you mean about how we're not compensated?
Can't bill.
Well, yeah, go ahead.
Yeah, I was just going to say nurses and social workers typically can't bill for a lot of what they're providing in palliative care, right? So APPs and physicians are the only ones that can, except for the new bill, which will hopefully change things. Only physicians and APPs can really get reimbursed for their work.
Right. In other words, you get paid. Your whole team has been
Right.
hired by your organization.
Exactly.
They take home paychecks. They don't work for nothing.
Right.
But the organization does not receive
money.
any compensation for the social workers' work. Right. Yeah.
And interdisciplinary work, right? Even when social workers can bill for counseling, if a social worker and a physician are in a room together, they can't both bill for that time, even though they're both doing valuable work, right? Only one of those people can bill.
If I may make a comment, those that are speaking in the audience, if you'd wait till I walk down with the microphone, otherwise the recording's not going to pick it up. So if you would just, I'll run.
I am so sorry. Which bill are you referring to that is going to change the billing system for doctors
Or
and
palliative care.
palliative care?
For the question to, you want to do? You should take it.
Well, it's just that the way palliative care should be delivered is in the context of an interdisciplinary team, which means a doctor, a nurse practitioner, a social worker, and a chaplain. So the team goes out and sees a patient. The only person who can bill for those services is the physician or the nurse practitioner. Okay. So what we advocated for this year, last year, was for compensation for the whole team. In other words, the team gets paid for the team's work, not just the physician's work. So that's what's coming down the right. Yeah.
Sorry, poor woman. Isn't it a matter of the medical establishment to accept that palliative care and hospice saves money for the system? Isn't that ultimately what it boils down to? And there's a huge resistance to that?
So I think that we in this room and anybody else that's in the world of hospice and palliative care have to assume the leadership, because I think that the politics of it need to be in place. So we need to be the leaders because the politicians aren't necessarily always the leaders. And so the leaders will follow. So we need to make sure that we're electing people that really see and they have vision, that they have vision about where this medical system needs to go, because where it is right now needs to evolve. It needs to have a revolution. And they're going to tell me to stop talking in a minute. I know they will. But I have this right now. I also think that when Dr. Van Kirk asks the question about how do we do this hard work and are able to have the resource continue to be able to care for the communities that we are caring for, and so that means self-care. And how do we do that? And right now we have a medical model that really doesn't allow that, right? So is there something about that we need to evolve and have the 4-day work week to allow those who care for those who need the care to care for themselves so they're able to do it for the future? Because you're going to burn us out. So we need to find a way, and so that comes not just from the political, that means the institutions, that means organizations, whether they're the professional organizations that are our voice, and like the American, like the Maine State Nursing Association, wherever. And so those are the really radical things, but you know what? We need radical change. Because it's not as simple as, okay, I'm going to do yoga today. You know, you need to be able to have the time to be able to do that and care for the people you really care about, which is those patients and families.
Can I just follow up on your question, just to be a little bit more specific? You know, your program directors, your leaders in your organizations, do you think that your leaders understand the value of palliative care? Are you a cost center, or or do you generate revenue? And I mean, I think that's where things get put.
So I think that I think that the leaders are coming along to understanding what palliative care is. There's been a lot of work of education in our culture, and I think palliative care has gotten a lot of attention, even more so with COVID. But it doesn't change the fact that when the finance people think about budgets, the soft dollars cost savings is a language that they understand, but it's not a language that they value. And when we're living in this fee-for-service model, I think we will continually be limited trying to adjust ourselves to meet these quality measures or whatever it might be that would let people see the inherent value that we know. And the other piece about it is you speak about cost savings, and it's whose cost savings? It's really the payer's cost savings and not necessarily the healthcare institution that's writing the paychecks to the palliative care team. And so that's a conflict in values. And until we straighten that out, I think we'll be, our programs will continue to struggle and be limited.
I was going to say exactly what you said. Well said.
You haven't given me hope yet.
But there's a bill, and it will start with main care. And it's
You're hard, Jim, you're hard.
Go ahead. We've got some questions.
Yeah, we need to talk about history here a little bit, because I went to the first meeting of the American Academy of Hospice and Palliative Medicine a number of years ago.
In 1996?
Yeah?
I was there.
And at that time, one of the problems was that hospice was beginning to get money because it was a cost saving over regular Medicare. And that went for about 3 years, when regular Medicare started to come back, and now hospice is the most rapid growing cost center for Medicare. So part of the problem is we're fighting against a bunch of silos that are being compared with each other, and there's nobody actually looking at savings. We're not looking at savings because that's not how we produce our reports. Nobody else is looking at savings. And you have essentially no leverage, because the discussion we're having now is the same one that we were having back then. And it really has to do with how we finance healthcare in the United States, which is very different from a number of other countries, including England, where I spent some time looking at hospice. And hospice was allowed. They didn't control what doctors could do in the same way. You didn't have to identify what the actual procedure was with a number attached to it that we were doing. But right now, if you don't have a number to attach to your procedure, nobody knows what you're doing, and we can't agree what the numbers mean anyway. If you look at what happens when we try to diagnose that. So we really have to look at the entire way that healthcare is financed. And outside of that, we're going to be in trouble, because we're just going to be one of the many little pockets. And it's all also broken down because hospice is now asking for money, and palliative care is now asking for money, and primary care is asking for money. And we can't even explain to each other where one of those groups stops and the next group comes. We have to be integrating those services, because we are never going to produce enough primary care providers to deal with the need. We're never going to produce enough palliative care providers to deal with the needs that are out there unless we kind of make this education, this training, generalizable across the whole group of people that are looking to move medicine from its technological base to some other place of care and caring. And we have to do it that way. We can look and say, it's the medical establishment that's doing it. No, it's nurse practitioners that are doing it. No, we don't pay social workers enough. We haven't even talked about chaplains as a payment source or volunteers as a payment source. And I think we have to take a very different approach than we are, because I don't believe there's a year in the 40 years I've practiced hospice when we didn't have exactly the same complaint about billing. And it hasn't changed. There's another law, but we got to start dating the laws that we're putting our hopes into, because there's 1996, 1997, 1998. Hasn't changed much.
Becca, do you want to say something about the different skill sets, the generalist versus the specialty skill set?
I really think that you're right, that part of the solution to expanding access to high quality, whether we call it palliative care or serious illness care, is making sure that everyone has sort of a core set of skills. I think, I don't know what exactly Lauren's looking for me to say, but do you want to say it? Good. Okay. I was going to say that I think what we do know is that it's really challenging to integrate palliative care into primary care, and many of the times that we've tried to do primary palliative care interventions, we have not seen the same benefits for patients and families. And I think probably there's a lot of reasons behind that. I think one is that our training and our expertise matter, but I think another is that it's the whole culture of how primary care works in this country that makes it really difficult to integrate good palliative care into the structure, right, of your 20-minute visits, and how do you actually carve that time out. And there's not great interdisciplinary team support, which we know is really important for palliative care. So I think we're a long way to go to figure out what those primary palliative care models are, but I certainly agree that we have to figure out something that's more integrated, because we won't ever have enough specialists to see every patient with serious illness. And then I also think from doing a lot of primary palliative care education, which I know Lauren started a lot of the programs at Maine Health that I now work in, you can train a bunch of people in serious illness conversation and really work with people to learn to respond to emotion, but if they're not seeing that out practiced in the medical world, which they're not, and they're not having anyone to help coach them and reinforce those skills, I think it's really hard for those skills to actually change practice. I don't know what you were. No.
I will not disagree with you that the quality of primary care is horrible, especially with respect to the issue of patient care.
Yeah.
Okay. The training is about 20. No. Training is about 20-minute visits, or now 10-minute visits. The training is about how you maximize your billing.
Yeah.
The training is not how you take care of patients.
Yeah.
Okay, and there's very little patient care going on at the primary care level, partly because people like my daughter, who's an obstetrician, claim she does primary care, which is an argument we have at the dinner table all the time.
I think part of the question that I don't mean to interrupt, but I think that part of my question was, palliative care, it just is so common sense, right?
Right.
To just, develop that relationship with the patient and ask them what they want and explore what their goals, values, wishes. Why does it have to always be a subspecialty? Well, guess what? It can't, right?
Yeah.
Right?
Yeah. We really ought to be calling it patient-directed care, because that's the thing that covers all of the things that we're trying to do, whether it be hospice, whether it be palliative care. We're just helping people give us the direction for what they want to do, rather than sending them off to have a procedure done or an evaluation or assessment done for something they don't want to have fixed anyway.
This side of the room is quiet, or I'm not seeing you. Go ahead.
I don't have a microphone, but I have a loud voice. Yes, I do. I have a loud voice, too, don't I? Yes, I do. We're sitting over here and celebrating, because we are making this work in a tiny way, and we are doing it. And I think...
so identify where you are.
So I'm Kathy Amsden, and I manage social workers, chaplains, and I'm immersed in palliative care with RN navigators and the palliative care team. What we've been doing for a long time...
Androscoggin.
At Androscoggin Home Health Care and Hospice. If I don't say that, I'll get shot, right?
I'm trying. I'm trying to help
Thank you, Lauren. You are being very helpful.
Very comfortable.
That's right. That's right. We've got Katie there now, too. So I think what we've had to do is start with the generalist practice by making sure that we've trained. And of course, I do everything with the folks that I work with. That in terms of social workers, chaplains, we are ingraining into also PTs, OTs. We train folks to have the generalist kinds of conversations. But I have most influence. My sphere of influence is on social workers. So from home health, we're already working in home health with the social workers, knowing those conversations and having those conversations as upstream as we can when we're in there in home health. Those social workers then are also then moving into palliative care because we have credentialed our LCSWs on staff to be able to be billed. So what's exciting about it is we've got Jen's over here, and she's going, "What's everybody talking about? We're doing this already." And she's really one of the folks who shows that. She's in home health, seeing home health patients. When they're done with home health, and if they're in palliative care, she can jump in and continue to see them in palliative care. And very often, she's moving people onto hospice from home health because she's involved in the conversations. So I guess we want to celebrate a little bit of success that we've been having in a small way to actually begin a model, even if it's tiny, and try to develop it and grow it and get it bigger as much as we possibly can. And I've got Donna over here, who's a chaplain. And nobody can have her after I tell you this. But she's also an LCSW. So we're going to be moving, we've credentialed her, even though she's a chaplain in hospice, to be able to work as an LCSW doing spiritual counseling and palliative care. Now, Jim's point is good. We just don't have enough staff. We're drowning in trying to get enough staff so we can actually pull this model off because we've got the people to do it, but we're trying to just figure out how to see so many patients. So anything else from this team want to? We've got our navigators over here. We've got our wonderful coordinator who calls every patient. We're really actually pulling this off, and I want to enjoy that for a minute.
Yeah. Kathy, I think what you're pointing out is that, we're evolving, right? I think we're evolving. I can't wait to hear your presentation tomorrow, Cord. So the Advisory Council did a survey. Cord did a survey for us in 2016 and sort of documented what types and how much palliative care was being done in our state. And then he just repeated it this past summer, so we're going to be getting the results. And I'm predicting that we're probably going to be seeing growth in the community-based palliative care, don't tell me, community-based palliative care delivery, because in 2016, there really wasn't very much going on. So, I just look at the Androscoggin table over there, and I think we're going to hear different things. Any thoughts about that, about different types of palliative care in different settings? They're challenging, right?
So we're talking about community palliative care, and I pointed at my table of community palliative care colleagues over there. And as Northern Light, and you'll hear more about this tomorrow in my breakout session with these ladies and also my colleague over there. We have palliative care in inpatient setting, in clinics, and in homes and assisted and facilities. And I think what's challenging is trying to, just because you say palliative care, each program might be different. Different programs are different locations are different, and how do we get patients to the program and in the setting at the right time, at the right place for that patient? So that's one of the things that we've been working on.
Question here.
I'm just curious about the bill, what the actual bill is that you're putting forth, like the numbers. Do you know the
numbers? What numbers?
LD.
LD 1064.
LD 1064.
It's
okay.
an act to increase the utilization of palliative care in Maine. Yep. And basically, the core of it was just to create a Maine care benefit for community-based palliative care services. Okay. Yep.
I have a suggestion for making palliative care work better. There are a lot of people have a hard time saying yes to hospice, but they will say yes to palliative care. And there's a whole bunch of volunteers out there only ready to do that kind of work. And I say to make palliative care work better, to really get those volunteers working for palliative care.
Yeah. Yes. Those community-based supports, right? Yep. Yep.
I want to come back. Can I make a comment? Yeah. You were talking about, primary palliative care, and I just want to acknowledge that I think it's hard, even if you are taught how to have compassionate listening, to do it if you never receive compassionate listening. And that we have a staff in the medical world right now that was burnt out before, and now it's beyond description. And so it's a lot to ask. And I don't know the answer, but I think it's just like this, we're having this listening session now, and we all get to be supported by each other, and remembering that your primary care doctor has probably had a hard day too.
Mm-hmm. Well said.
Tiffany.
Oh, wow. Isn't that nice? So there's been a couple of people have mentioned that we're having trouble getting people to come and work in the palliative care setting. And some of that is probably because of funding, because you do get a lower salary for working in this practice. But I think a lot of people would find the rewards for that may outweigh the decrease in salary. My question is more, is it that these people don't know or aren't as familiar with ways to help with self-care to deal with the additional emotional stress on the palliative care provider? And if that's something that the practice in general is looking at, trying to provide more education on to people in the field and people perspective that might be looking at this field, including people who are doing fellowships and internships as they're going through school. I work in a cancer center, and I know several of our providers, specifically nursing staff, have left because they didn't know how to cope with the pain that they were feeling in response to their patient's pain. And I didn't know if that's something that has been reflected and is in the works.
What do you think, panel? Is resiliency, is that part of your curriculum?
That's what I was going to talk about, the word resilience. Yeah. Because when you say self-care, you're putting it right back on the clinician. Yeah. A true healthy environment is helping to facilitate building resilience among your team members all along. And that's part of what you do, just as important as it's important to know which patient you're discussing at IDT that week. Yeah. And that's, where there's, again, that whole thing about time and what's billable. But the programs that work the best and the results that are the most consistent are the programs that have built-in resilience, for attention to that resilience, and may even staff according to that, and make that a topic that's not at the end of the list on your day that you have your team meeting. What's your thing for self-care kind of thing going to be?
Well, and I think there's a lot of variations in how we understand what resiliency is. To me, it's not a day off with a yoga class, right? It's not, right? It's how do I go in this room, get in this hot, muddy water, and then get out again as a whole person, as a whole human being. So how do you do that day in and day out? That's resiliency.
Yeah, I was going to say a couple of things. One thing is that I've really, over time, started to understand that resiliency or kind of ability to do this work for the long term is different for each person, just like we understand that goals and values are different for each person that we see. And so what kind of helps me get through my life is going to be really, and the amount of work I'm willing to do and the amount of time with my family that I need or whatever is different than it is for each other person. And so I think one thing is that we have to, as a field, sort of respect each other's limits and boundaries. But I also think, kind of back to what, and then I think on the positive side of palliative care, it is the fact that we have this team and that we can all support each other, and we can lean on our social workers to help when the providers are feeling really fried, and then vice versa, and kind of use our chaplain to help us have wellness activities. And you asked sort of what programs we have. At Maine Health or Maine Medical Center, we have wellness every week. That's a half an hour activity. Is it enough? No, because as Jim said, I think, we are constantly just asked to do more with less. And as the value of palliative care has become apparent, our consult volume has simply exploded. And staffing to support, 20 plus consults per day, well, we're nowhere near that staffing at Maine Medical Center. So I think it is number one, there's lots of things that we can do. And number two, also, I think the system really does have to change because as Lauren said, this is not something that we can sort of just handle ourselves until we can really staff appropriately for the volume that's coming. Or, as you said, make it so that primary hospitalists and others have the time and skills to do the work.
And part of resilience is being seen and valued.
Sure, definitely.
That's a huge part, valued.
Another piece to the whole picture is about public education. And I used to do workshops on getting people to talk about end-of-life issues and advanced directives. And when I bring up palliative care, if there were 10 people in the room, 9 of them hadn't a clue what palliative care was. So I think that's another important part, because then once people know, they will ask for it.
Will you come to my breakout session tomorrow? Because I think messaging is a huge problem. I think it's huge. This program defines it one way. This program defines it another way. I define it another. I mean, we're all over the place. And until we come up with a consistent, clear definition of what this care is, it's going to be hard.
I do think, just adding to what you said, I do think you're right, patient understanding of palliative care in the families, So when I'm in the hospital doing a consult, I'm spending the first half hour telling them I'm not wearing the black cloak, explaining the difference between hospice and palliative care, and I'm usually greeted with this, because they're really afraid that I'm going to be coming at them. And so for that first half hour, it's just about sort of bringing it down so that they recognize that I'm there for their agenda, not my own. But you're absolutely right. And I think about that transition of what happened when hospice started. That whole social change that had to occur. And so that took about 20 years of education that was constant to the communities, to senior centers, to everywhere that was willing to have a speak. And it's like palliative care is starting that. So it's going to take that whole 10 years of constant being vigil and of getting the message across. And the other thing, too, just like hospice proved itself, the outcomes were good. Palliative care is proving the outcomes are good. And that in itself is a selling market. Yeah. Yeah.
You just used the term market, and that has been in the back of my mind, because big business is quite effective at marketing things they want to sell. And so is it a matter of finding a framework for this which can grasp people? And a quick story, we saw our one of our grandchildren who's in university right now, and another grandparent had just been very ill and died. And it took him about 4 days to get around to really wanting to talk to us about it. But he said, how come no one will talk about sickness? And how come no one will, my friends don't want to hear about it. So how can we market this to the point where it's, and I hate to use that word because I know it's got a really nasty slant to it. How can we market it and sell it?
Did you have a suggestion?
So I'm a nurse practitioner. I know a lot of people here because I've been practicing since 1985. Actually, I wasn't a nurse practitioner then. I was an LPN working at Eastern Maine with Dr. Askins. So I remember hearing doctors say, why do I want hospice to come in and hold somebody's hand and tell them it's okay to die? That's when I started getting involved. As a nurse practitioner, I was in private practice for a while. You don't get paid. I am now an employee of Bucksport Regional Health. And we have a system that's very similar to that. We have licensed social workers. We have a social worker who is also a chaplain. We have RN case managers, and we have physicians as well as nurse practitioners. My question to everybody here, and this goes along with the marketing, I'm not one to take no for an answer. Anybody who knows me knows that. I think that our sitting back and saying, it's okay if you pay me nothing, I love to do this, is what's getting us into this problem. I write letters. I've actually written to Senator King, and he's responded to me about the hospice problem and nurse practitioners back when we couldn't write for hospice because I didn't think it was fair. And I think we need to stand up and let our voice be heard because this is a valuable service. I start talking to my patients about death and dying when they turn 18. I'm known as the nurse practitioner. They walk in for their 18-year-old physical, and I hand them advance directives. And we talk about it. I talk about my patients all the way through because as a primary care provider, not a physician, that is important. It is very important to have that continuity of care. And I am revolted that so many people think that a primary care provider, yes, I know you only get 10 minutes, but why did we allow that to happen? We need to fix that. We need to stand up and say, that's not allowed, because our patients don't want that. They come to me all the time saying that. So we need to stand up. We need to let our voice be heard.
Got someone up here.
I'm Kim Murray. I work at Martins Point Healthcare. So a lot of you have talked about the billing, and I was thinking along with the marketing. I manage oncology patients primarily, and I'm having those talks. So why not partner with the people that have these providers that like to do this in this setting, social workers, nurse care managers, at the providers, at the Anthems, at the Aetnas, Martins Point, let us be part of that. But I will say, I, like you, over the last few years, I have noticed that huge jump in palliative care being noticed and out there. A lot of oncology starting it early, which is great. But I will say recently, I have a patient that was made a palliative care consult, but told they have to wait 2 months. And he could be dead by then. So I agree with you. I think more needs to be done, more partnership, getting into the insurance companies, maybe talking with us, helping us to be that partner with you. Maybe that's part of it.
We've talked about that at the advisory council. In fact, for a while, a payer-provider collaborative relationship was something we talked about for a bit. Yep. Okay, what else? Anybody else?
Somebody has a question.
Is it okay if I, as a marketer, if I jump in here? I think we had 3 brilliant points made, and they all dovetail just very quickly. And for me, when I first heard the word palliative, I had no idea what it meant. I don't know any other place where I use the word palliative. I don't know any derivative. And so I think when we talk about it, when you talk about marketing, who are you trying to reach? Are you trying to reach the general public? And if so, maybe begin thinking about terminology that the general public can understand. Patient-directed care, from my perspective, beautiful. I think that says exactly what it is. And palliative is, I know now what it is, but when I first heard the word, I had no idea. So that's all. So thank you for bringing that up.
It is a funny word, isn't it? It's a real funny word. Do you know where it came from? Do you know who first described palliative care? Anybody know? Dr. Balfour Mount. Right, right. So he's in the Royal Victoria Hospital in Montreal, right? He was a chair of surgery or something, and got interested in this hospice thing that Cicely Saunders was doing across the pond. So he went there, learned hospice care, brought it back home to the French-speaking Quebec, and they said, "What? Hospice? Ew." So he apparently sort of translates to something that's not so nice. And he said, "It's okay." I had dinner with this gentleman way back in the 90s, and he sort of described it to us at the table. I'm just kind of like looking in the mirror, shaving, going, I've got another word, palliative. I'm going to call it palliative. So it was really without a lot of thought. It was just, and he was the first one, frankly, to bring it to North America. Florence Wald brought it to Connecticut, but he was the first one who used that word, palliative, and it was really just because he didn't know what else to call it.
So it was a shaving derivative.
It was a shaving. And I think we've struggled, right? And then in this country, of course, we have hospice and palliative care, which was going back to 1996 was a very political and challenging moment for our field, because we were the Academy of Hospice Physicians, right? Before that meeting in Snowbird, Utah, we were the Academy of Hospice Physicians, and we had a vote because the Belmont was there, and we were having this big discussion about we have to move forward, and there were people in the room who really didn't want to let it go, right? Didn't want to let our lovely, beloved hospice go. So we settled on becoming the Academy of Hospice and Palliative Care. Our specialty is hospice and sometimes I just want to get it out of there because I think it holds us back, So anyway, just a little sidebar, just interesting. Go ahead.
One thing, I hear what everybody says, because I think I've been doing palliative care now for 18 years as a physician, and everybody in my hospital would say, change the name, it's not a good name. But it's the same thing like cancer is a word we didn't want to say for the longest time. I think because people are uncomfortable with it, it just means we have to educate them more. And it's really about what you said, anybody who talks to a patient. I always say that to any patient when I meet, and I do this exact same thing as a physician, you spend the first 15 minutes just trying to tell them that you're not there to deliver this awful news, but to tell them that this is about making your life the best it can be despite your illness, period. It's about living your best life, and it's about living your life. And even hospice is about living your life, but it's when there's less time. But if we turned it into something positive, and whenever you say that, most people say, "Oh my God, how come I didn't meet you sooner?" But that's their usual response to that.
Yeah, I agree with you. I think that language, we just need to teach language. And I do like the word palliative care, and because to palliate means to ease. And that's exactly what it is. And I think if we look at 20, 25 years ago, I think the same would stick with marketing. What's hospice? So here we are now. What's palliative care? So it's the open door for us to be able to explain and explore it with them.
But I think that people, you hear palliative care, and I know where this is going, right? I mean, they figure it out.
Yeah. It is, but one of the things that I do tell them, and it is true. It's like, oh yeah, so what's different? But you know what I'll say to them is I'll say, you know what, I just need to let you know, okay? I'm not here for just today. And as a matter of fact, I've been following somebody for the last 4 years. Suddenly there's like, oh, okay. So there's a little bit of give them a little bit of reality about what we really do, and you just go with it, right? Yeah.
Are you talking about patients or surgeons?
Yes.
Candace, we have time for one more question, maybe? I don't know what our schedule is. That one over here. Yeah.
The thing that I see in the palliative care consult that works the best, or that I see the most reaction and kind of an aha moment, is when the doctor says, this is about people with serious illness, what you want and what you don't want. And the minute they seem like they have permission to say what they don't want or what they do want, it opens the conversation. So the person that doesn't want hospice, that wants full code, that's what they want. We can still talk about that. But then the ones that are like dying to talk about, this is what I don't want, and it works.
You're giving them choice. Yeah.
I think I've been thinking about a lot of things a lot of people are saying, including you. I'd love to talk further because that's really, I think, is the answer, right? Is to figure out how to empower and provide space and time for people and our primary providers in oncology and other situations. But I've also been thinking about this question of marketing, right? Because I do think that, sometimes in my role, I feel like I do this double talk, right? Because to administrators, we're going to be like, it's cost savings. We're going to save all this money. We're going to stop unnecessary care. And then you go into the patient's room and it's like, it's about what you want, whether you want the expensive care or you don't want the expensive care. So I do think that's one of the things that we struggle with as a field in our marketing of having these different messages that we use.
Right.
In
Different message for leaders. I mean, I think that the reality, and even if this were more expensive care, in other words, if it cost all that much more, it would still be better care.
Exactly, because at the end of the day, really what we should be able to market is that it is patient-centered care, holistic care, but that's not what the C-suite wants to hear.
Love it.
Yes, yes.
But again, the paternalistic beginnings of the medical profession is, what do you mean give patients?
Yes, yeah, it's true. And I like to think that we could use the argument that we are, seeing patients, we're giving patient-centered, holistic care, which it turns out most patients do not want non-beneficial, aggressive care, right? So that is why we ultimately save money, but it's just a more complicated message than many can follow.
The first question is, what do you want? I guess the first, what are the realities of your illnesses?
Right?
What's realistic, right?
Right.
Right. And then listening. Yeah. Yeah. Okay. Oh, are we done? Okay. Yeah, what do you think? I mean, it's 7 o'clock. We were supposed to be home by 7, or what?
Energized group. I'd love to capture the comments that we could, but probably, and then we'll introduce our dear Smith.
Yeah.
Everybody's ready to go home.
Anything else?
I was just going to say that I think that a lot of times language is a trip up for many people, and especially if they come from other cultures. And we have other cultures in Maine as well. What's wrong with using the word comfort? And to go back to what Toby had said about goals, what are your goals for care? What is it that you want? Do you want to go through all of this testing to determine what this is? And it's going to vary from whatever age the patient is to, it's going to depend on that. Because when I was 40, I would have probably had a different goal than I do now, for instance. And, it's really got to be individualized to the point of people understanding that this is about you and what your goals are. How do you want your journey for however long you have left to look like?
Right. I worry about the word comfort exclusively because, palliative care is not lesser care, it's different care. Right? Do you want to respond to that, any of you ladies?
I mean, I think the main thing that I would say is that what the studies show is that you can change the name and the reputation follows you. So at the end of the day, yeah, you can change it to support. People have done this. They've changed it to supportive care. It works for a little bit, and then eventually the reputation follows you that you are seeing patients that are towards the end of life. And so I think at the end of the day, it really is about, as others have said, education and focusing on the, as CAPCE has in their latest guidance said, we need to focus on the positive of what we bring and make sure that that's the center of our message and stop saying palliative care is not the same as hospice because that just reinforces that we are the same. So I think it's sort of following those marketing principles, but changing the name I don't think will work. And yeah, I think what you're saying, Lauren, is true, is that most people associate comfort care with less aggressive care, and palliative care should and could be integrated alongside the most aggressive types of care.
And just empowering them.
Yeah.
Empowering the patient.
Totally.
To be that voice against sometimes providers like I explain all the time, you know, a surgeon, even the sorry, I'm not good at this. A surgeon is invested in your surgery. You know, doctors went to school to heal people, to make people better, and that's the focus.
Yeah.
So patients are sometimes going up against doctors that maybe don't want to, like you said, don't want to go there for whatever reason with the patient.
Yeah.
But the patient's telling us, I'm done. I don't want to do this anymore. Or I can't live with this pain.
Yeah.
So a lot of times I'm empowering the patient to go have those talks.
Sure.
You know, with the, like, because I can't order it, obviously, but I'll say, you know, ask for a palliative care consult.
Yeah.
Or at Martin's Point, we send it over to Dr. Letelier.
Yeah.
Or I'll get the doctor to order it at Martin's Point. I'll say, hey, I had this conversation, and, you know.
One of my colleagues likes to say, you have your heart doctor, you have your liver doctor, you have your kidney doctor. I'm the you doctor as a palliative care doctor, which
that's good. I like
Can
that.
I just,
it works
you know,
for her.
Yeah, I just want to get back to the doctor sometimes. So doctors aren't always bad when they want to do more things.
Right, I'm not saying
no,
that either,
I just have
you
to say,
know.
sometimes doctors love their patients.
Yeah,
you know?
that's true. And that's what I tell them.
I've seen that before.
So invested in you. And yeah.
No, I'm not kidding. We had this one, I don't know if she works there anymore, you know, one of these, a hematologist who, remember taking care of one of her patients with myelodysplastic syndrome and, you know, needed transfusions 2 times a week, 3 times a week, and always in the hospital. And he finally just said, you know what, I'm done. Just send me to hospice, I'm done. And she was upset. She was really, really upset. And she was a little mad at him. She said, you know, so he doesn't want to go anymore. Why doesn't he do it for me? You know.
Oh no.
She loved him.
We're invested in them, you know, and so yes, I totally agree. And so I help them sort that out. And I think sometimes when they understand, people are trying to save you. They're trying to do the best for you.
Sure.
You know, and we are invested in your care. I think that helps them to process it.
Yeah, I feel like that's a big part of the value of palliative care that is impossible to measure. The support you just talked about, like to our colleagues, and the colleagues as being some of, you know, the people that benefit from. They're also the people that we're serving.
Yes, Candace.
Lauren, I'd love to ask our folks over at the table in the corner that are hiding, the speakers for tomorrow, if they, in listening to all of this, if any one of you, Betty, Court, we haven't introduced them formally, but, and Jim, have comments, but especially Betty, Dr. Betty Farrell and Dr. Court Kastner, who you will meet formally tomorrow. That's all I'll tell you about them tonight, you know. No, just kidding. They're just amazingly accomplished people, and they are going to be talking with you tomorrow. But in listening to them, because they've both been involved in this field for years and years and years in Colorado, and Betty is at the City of Hope Hospital in California and has published 600 and some articles, so she's been busy. So do either of you have a comment in listening to all of this?
So sort of my brief reflection of the evening. First, I've just been sitting here thinking, I'm so glad I came this evening and got to sort of listen, you know, and it was a reminder about listening, and just to be here this evening and to listen what's on your hearts, you know, really informs me about being here tomorrow. So I think that's the gift of the evening, is the reminder to listen. You know, my second reflection is Kelly, who played the flute, still in the room? So I'm supposed to talk about spiritual care tomorrow. And I sat here this evening, and, you know, as soon as Kelly started playing, you know, first I heard these notes in my ears, but then I heard the notes in my soul, and I thought, I really want to go home right now, because, like, that's spiritual care, right? That's spiritual care. And so that, like, listening to her is a lot better than everything I'm going to say tomorrow. I just have to tell you. Okay. And then I think, listening to these wonderful people, the ones at the front of the room, but the ones throughout the room, what I've heard tonight is that you're all here in this room for the same reason, because you understand what's important, right? And you are trying to pioneer this field that's still undervalued, and yet you care deeply to do it. And we're still on such a learning curve of teaching, a really broken system, what matters. And then I think the last thing is, I'm just so grateful for this table of people right here, who said, but we're doing it. And so I think that's what I have heard tonight, is that, but every day, everybody in this room gets up and you go and do it again, right? And so you come here to sort of be refilled. And everything you have said tonight is the same conversation going on in every state in this country and everywhere around the world. And so we just keep going and we learn from each other, and it's worth every ounce of fight that we have in us. That's all I know.
I'm Cord, and have been thinking on many of the same things that Betty shared, that tonight is so powerful because it provides the context for many of the comments tomorrow. And I was going to say, Jim, you're fortunate because Betty's going to answer all your questions tomorrow. So I'm bringing the results of a survey that we did this year on contacting every hospice, every hospital around the provision of palliative care. And my colleague, Kathy Wagner, who was the one who spoke with many of you in the room, did an amazing job gathering this information. And so I'm going to be talking about what palliative care looks like across the state, more from a quantitative perspective. What do your interdisciplinary staffs look like, and that sort of thing. Those of you that participated in the survey, you're queued up. You already know what's coming, or at least you know what the questions are. I'm going to bring the summary of the answers tomorrow, which hopefully the plan is, and this is compared to a study that the same people, Kathy and I did in 2016, looking at the change over time in the provision of palliative care. Hopefully this is the kind of information you can use for the advocacy that you're talking about. Here's why we need change. Here's why we want to go in this direction. And hopefully that's the plan. That was Candace's master plan, to have some data to back up the passion in the room. And you do, and you will. And looking forward to tomorrow.
Hopefully it's information that y'all can take back to your leaders too, right? To, just see what everybody else is doing. So Candace, I think we're good. I think people are going to start falling off their chairs.
Oh dear, oh dear. Well, thank you all in the audience. Thank you all for your courage to speak up and share your comments. Thank you to our panel members, Rebecca, Vanessa, Jackie, Lauren. Thank you for facilitating. And all of this is recorded,